Okay. All right, very good. Good morning, everybody.
Good morning.
Good morning.
Hey, good morning.
Hey, Greg, do you want to get us launched here with the?
Sure, yes. I will do roll call. Trey Addison,
Present.
Greg Sini's present, and present. No, I'm kidding. Present. Bonnie Berman,
I'm here.
great. Laura Stevick Rust,
Present.
Jennifer Droust,
Present.
Tina Hockwalt, not present, and Vernon Hamajan, not present. And I can honestly say, I was just looking through my notes and I did not send out the new meeting minutes. So I will send from our last meeting. I will send those out. Maybe we didn't have them because it was, I think our last meeting, was that the task force meeting?
Yeah, that was the full group. So we wouldn't have had.
Okay, thank God, because I was like, oh my gosh, I don't see any. So we don't have to approve any meeting minutes
No,
for this
but we're going to
particular.
do last week. Do some quick screening of you, Greg, and then we'll be done with that.
Well, I was looking through and I was like, oh my God, I didn't do any meeting minutes. This is not good. So here we go. I'm off the hook.
We did meet last week and we went over the 3 new buckets with the pre-diagnosis, early diagnosis, and treatment.
Okay, so I did.
I thought that was 2 weeks ago, and then
no, I think you're right.
Last week was the 3rd of May.
Okay,
yeah, so I owe you meeting minutes for the 3rd of May. And I will send those out right after this meeting, and I guess we'll have to approve them at our next meeting.
Okay. And then Greg and I will be calling you, Jen, for a quick little screen there. All right, then maybe what we could do for today, since I know that we, at the last meeting, we did put those 3 pillared buckets together, broke up again into our teams to look at how to flush that out even further. The proposed format was looking at the factors that are barriers, then more specifically what the barriers look like, how we can overcome those barriers, and then how would that look in terms of the impact on the pillar that we are addressing. So maybe we could just start with, well, we can go in the sequence again, I think linear. So I think of, the early onset pre-diagnosis, which was the bucket that, the pillar that Trey and I were assigned to, but open to whoever might want to start presenting their pillar.
So say if we go linear, then we can start, Bonnie and I, with our pre-diagnosis and mitigating risk factors. So, okay. Everybody see that Word document?
Yes.
Oh, sometimes the 2 monitors is annoying. Okay, so Bunny and I met, and so we talked about breaking this pre-diagnosis and mitigating risk factors really into 4 interrelated but kind of distinct buckets, recognizing that public awareness and education, both the health and public health workforces and systems education plays a role in this. Population health, social determinants of health, and disparities are related. And then really, what is the public health and healthy behaviors education? Lots of overlap between these things, and really emphasizing that these intervention strategies are really needed in all of those areas to affect change as a whole, and that silos between public health, healthcare, those workforce, those systems in place, silos between kind of how we look at social determinants of health and disparities really play a role in prevention and potentially limiting prevention strategies. We need integration on multiple levels, both at community, local, state, and federal levels, and kind of emphasizing that inputs, outputs, outcomes as far as determining the effectiveness of those interventions. So in that first bucket, public awareness, recognizing that there's a lack of information and also misunderstandings about the benefits of early detection and diagnosis, the relationship between healthy behaviors and brain health, and then loneliness, social isolation, and cognitive decline. I think certainly with COVID has been emphasized for all of us. There not much kind of public and private partnerships. I think one of the things we really talked about is that a lot of advocacy around health in general is treating the disease. So kind of using, cardiac disease as an example, all of the lobbying through the ACA, et cetera, from cardiology groups really focusing on, the treatment of cardiac illness, which is certainly important, but not a lot of recognition and moving that into the, pre-diagnosis mitigating risk factors standpoint. So that, how do we tie all of this together? And then culturally sensitive and appropriate materials and approaches certainly needs to be discussed as well. When we look at the healthcare and public health workforce and systems, again, lots of silos between healthcare, public health, community-based organizations, between different groups within healthcare, again, cardiology and geriatrics or neurology, and there's a lot of overlap between those things as far as how we prevent negative outcomes. Lack of education across the board, both pre-professional as well as professional, and not only healthcare with your physicians and APPs, but also your allied health with physical occupational therapy, speech therapy. Speech therapy probably not a great example, but a lot of limited training, but then how do we also harness interest and passion for caring for this population earlier up front? Shortage geriatric providers, which is a national challenge for sure. But I did catch a headline that said that last year there was a 10% increase in folks applying for geriatric fellowships, which is great news, but still less than 50% of fellowship slots fill. That integration between cognitive and brain health, as well as other specialties, and that really not an incentive to focus on brain health throughout the lifespan, and really recognizing that if we're mitigating those risk factors, that's something that has to happen early and lifelong. Kind of tying that into health and education disparities throughout the lifespan, really driving increased rates of dementia in underserved and minority populations, and then the importance of interprofessional education and training. For the public health, social determinants of health, recognizing that all of these things are risk factors to developing dementia, and so really having to take, it's an immensely broad view of how we about the risk factors in different populations and how we can strive to mitigate that risk. And I'd like to just point out the inconsistency of the community design and resources, from everything from prevention, wellness, physical activity, food deserts, et cetera, that really can play a role. And then kind of more the public health and healthy behaviors that are important to not only reduce the risk of cognitive decline, but chronic diseases in general, the importance and connection relationship between brain and physical health, that misinformation or lack of information still, that presumption of senior moments and how ageism plays into a lot of downplaying and or fear around cognitive decline and geriatric syndromes in general. Again, that cultural sensitivity piece needing to play a role in there. And once again, those silos and how do we all work together to really build a system that moves things forward. So that was our first foray through thinking about that pre-diagnosis and mitigating of risk factors. Thoughts and questions?
Go ahead. Somebody had questions?
Bonnie, add anything?
No, I think you captured it beautifully, Jen. Thanks.
Can you scroll down a second?
To the second page.
Yeah, please. Awesome. Now, do you have anything that talks to the measures of impact?
So we did discuss that, of what that might look like, and because of, so much of this is, really years ahead, hopefully, or encouraging, building that system out that's years ahead of the diagnosis, that certainly becomes a challenge. But so thinking about it more, really from the public health standpoint, measures of, overall health metrics, rates of obesity, rates of hypertension, within the population, looking at, probably some of the community structures, and measures that measure the walkability of a community and a neighborhood, measure the food access in a neighborhood would be things that we would we're talking and consider impact measures.
Yes, so what we did, and we put it, instead of repeating it, Greg, we put it up under key tenets, and that is that, as Jen said, that the total impact will take a long time, and that we are suggesting using evidence-based proxy measures that would be focused on the, as Jen said, not the impact, but the outcomes that we know lead to the impact that we are seeking.
That makes good sense. All right. Did you capture what we needed there, Greg?
Yeah.
Yeah. Okay. And I think certainly open to continuing to massage what this document looks like. I think obviously that's a great comprehensive start to looking at the process. And impact is, we shoved it in there, but it may be that for me, that looking at impact was really when we get our consultant on board, what resources are we going to need to pool, and will measuring impact be one of those resources and resource tools that we're going to need? So I don't know that we'll necessarily, to your point, be able to say, well, this is actually what the impact's going to look like while we're building the bridge and going through it. But I think, once we know that there is a consultant in place, for us to be able to reach out and go, here's what we need to continue to build this framework makes sense. So.
Yeah, and certainly, I mean, within that, and as we're looking at, pre-diagnosis and mitigation of risk factors, right, at some point in time, of really, I mean, and covered a lot, but generating like a list of like, these are the risk factors and these are the potential interventions for each of those risk factors, through that consultant work, and then what are the outcome measures, those proxy measures for those things, kind of being part of that.
Yeah, great, nice job, very good. All right, Trey, do you want to open up, since we're wading through the linear fashion now? We've got our mitigating and pre-diagnosis. I know that when I took a look at our section, and I see that I've actually populated it on the wrong form, but that because in many ways there was a lot of overlap, as you can imagine, where they're not just demarcated like here's pre-diagnosis and then here's early diagnosis. But so some of that overlaps, but I don't know, Trey, if you caught that and put that on the right form for us, or if we still have our title wrong, but it doesn't matter because it's still the barriers and the impact. So do you want to open that one up, Trey? And
yeah, I was editing some of it, so I'll open up the version I sent you last, Lori, but give me 1 second.
Oh, and while we're getting that up, I think that was one of the pieces that kind of got lost in the shuffle. I understand last week was a pretty crazy week of getting this worksheet. So if we could send that worksheet out, that would be helpful.
Absolutely.
Okay, can everybody see my screen?
Yes, and ignore the pre-diagnosis because again, we've used the form. Again, the form was also one of those where, thanks to Greg, who was trying to help us with the formatting, we wanted to make it clean and pretty and dovetail it into at the end what the state's plan looks like. But it can be labor intensive to go, okay, now I'm typing and the boxes are moving. So we put it in this bucket, but it's really looking at, if you want to identify our pillar name, Trey, and then we'll, because we're not in the pre-diagnosis, we just did that.
Yeah. Give me 1 second. Why is this not working? All right. Sorry about that. I'm having some technical issues. What's going on my computer?
Greg, do you have from the minutes just the name of that pillar, and we can just start with that?
Oh, yeah. Hold on 1 second.
Not that I think for the purposes of us reviewing, we probably don't need to. We'll fine tune and tweak that and then get.
Yeah, it's the name of the. Hold on 1 second. Early detection and diagnosis is the name of the sheet, but let me just double check to make sure that's the title.
I think that sounds right.
Early detection and diagnosis is the title name of it.
Okay, yeah. So pretend that's what you all see on the screen, and we'll get the actual format when we get going here.
And I just resent those out. I resent the worksheets out. So, and they're all three on the same email. So you just grab the one that you need.
Okay, great. All right, Trey.
Can you guys still see my screen? For some reason, it's weird on my end. So.
We see it.
Okay. Okay, sorry about
that.
Yeah.
The one that has the added pieces in there, so you may have to just walk through your additions because I don't see that in this form.
All right.
So.
All right, good deal. All right, well, we'll figure out the technical stuff. So basically, one of the things that we had looked at is really looking at how does Ohio lead the nation on public health outreach awareness around early detection and progressive interventions. This is significant, especially on the early detection component. There's a number of programs across the country that are working on tackling this, as well as progressive interventions. I think that was a great add, especially I think Lori had mentioned that, and really how do we, not say prevention, but really progressive interventions in that way. So when we identify factors in a list of barriers, lifestyle, education on brain health, misinformation regarding normal aging, and lack of diagnosis.
And I'll pause you real quick, Trey, and I'll say that I think, Jen, obviously you fleshed this out really in a lot of detail and nicely. It sounds like here again is where we're going to start seeing more overlap, which gives us the richness of what we need to do to actually have impact. That the misinformation around normal aging is a huge one. And you talked about that, in terms of ageism and people thinking, oh, well, this memory issue is just because I'm 85 years old. And, if we start working upstream of those mitigating risk factors, but it also plays a role in early detection because people are not telling their clinicians or their family about these issues because they're thinking that they are a normal part of aging. And I know that has been a big initiative, across many of the healthcare systems and agencies. And so I know ARP is focusing a lot on this, Alzheimer's Association. So I just wanted to highlight that because we know that is part of mitigating risk factors, but it's also why we're not getting the early detection identified in there. So.
Yep. No, great point. And then when it comes to a list of barriers, access to healthcare, access to transportation, education of patient and family brain health, and really lack of routine and standardized cognitive screening in the primary care office. So obviously that's the list of factors and that's the list of barriers. When we look at step 2, it's sort of how do we overcome some of those barriers? Building statewide infrastructure to support early detection and diagnosis, really part of healthcare overall, taking a holistic approach. Standardized early detection screening across all levels of healthcare, at the ED level, primary care, health systems, et cetera. The second area, and we've talked about this before, really Project ECHO, and we also have what's called a Project Vital. And Project ECHO component is actually something that the Alzheimer's Association is doing through our health systems work and really connecting the dots for health systems and really healthcare professionals, really connecting the dots, helping people navigate through these systems and processes, and really increasing the amount of diagnosis that happens in all of these settings. So for us, that's exciting, and we've seen a lot of the work bear fruit. Also, Alzheimer's Association has Health Systems Project, and this is something that ODA has actually been helpful with, and we'll continue to have dialogue on. Is really the scale of impacting lives. So through health systems, that's kind of the direct intersection for a lot of people who are not diagnosed, as well as who may be diagnosed but still coming back and forth through a health system. So how are we preparing health systems to be prepared to understand what is going on with their patient, or what they don't know is going on with their patient? Is another area and area where we can overcome from a barrier standpoint. The third area is standardizing, really training in healthcare professionals, especially those who work in the long-term care setting. This has come up a number of times, especially in the General Assembly, around long-term care training and really standardization of that. Now is really the time to start to look at the opportunity, especially through the task force, to start to standardize training. And lastly, it's really statewide awareness campaign with the emphasis on diverse communities. The research and the data shows ultimately that individuals who are among or in minority communities have a higher chance of getting a diagnosis of dementia. And a lot of that has to do with some of the areas that we've already discussed, and really around misinformation regarding normal aging, lack of diagnosis, and the number one area that we've seen is lifestyle. Lifestyle plays a critical role, and by really drilling down into a statewide awareness campaign and looking at the emphasis on diverse communities, I know that's something that we definitely need to do. There is evidence in some states across the country who've doubled down and really focused on public awareness and looking at this through a public health narrative, where successes have happened, especially as it relates to just penetrating communities. Again, minority communities across the country or in specific states. Florida has done well at that, as well as California with their Hispanic Latino population. So as we look at that in Ohio, it's an opportunity for us to thrive.
Yeah, and I'll add to that, Trey, that part of that standardized training, we know we're starting to see the trends of finally having to pay attention to comorbid conditions like mental health issues that are separate and parsed out from the dementia diagnosis, and also developmental disabilities. We know that certainly among our many of our residents with Alzheimer's who have developmental disabilities have a higher tendency in their 40s to be developing Alzheimer's disease, and in many places those care homes, it falls apart. We can manage the developmental disability. Now they're aging and they've got this other comorbid condition, and there's just not a lot of awareness. And then when these folks hit the hospital, the care structure is really poor. So part of that standardized training, I think, is also to look at those comorbid conditions that are impacting the diagnosis.
Absolutely. Absolutely.
I would say one thing, to potentially tie in, I think this would go up under number 2, up top there, the IHI has a nationwide program that increasingly health institutions, they have lofty goals of getting healthcare institutions age-friendly. So there's Age-Friendly Health Systems Initiative through IHI that focuses on 4 pillars for older adults: what matters, mobility, medications, and then mentation. So both cognitive as well as behavioral health concerns are incorporated into that. Certainly anything along the way that increases or provides certifications, placards, little things to put on your emails to say we're age friendly, right, becomes an initiative or that's an incentive for healthcare agencies to participate in that. So that might also be something to look into. Is there a way to partner more broadly as a state level on that age friendly health system initiative with IHI?
That's a
great point.
Greg, were you able to capture that we could add that to our second category? I think that's really important.
Yeah. What were the 4 areas?
Sorry, yeah, they roll right off my tongue. So it's what matters. They're called the 4 M's. So what matters, medications, mobility, and mentation. So, and they include cognitive and behavioral health in there.
And that all rolls up under the IHA.
Yeah, the IHI Age-Friendly Health.
IHI Age-Friendly Initiative.
Which stands for the Institute for Healthcare Improvement, and they're just amazing.
Thank you
and
for
that. That's a state-run agency?
No, it's a federal organization.
Federal program.
Yeah. I think they're partnering with, and they're partnering with the John Hartford Association with their, with that work as well.
So Don Berwick was the head of it for a long time, who was also at, of course, head at CMS. So there's a strong, he really understands they understand the policy side of it. The other thing I'd like to add to that is there's the age-friendly emergency rooms. There's 2 in Ohio now, but so if somebody can't go for the whole hospital, the emergency room is a really important one as well.
Yep.
Okay. Yep. So lots of hospitals are baby friendly, right? So we're trying to get age friendly.
Mm-hmm.
You'd think it would be easier than it is. I mean, we tried that in a couple of our systems, and boy, it sounds so good on paper and it makes logical sense. One of the barriers, I think, is getting people out of their standardized way of doing things as healthcare professionals and thinking more broadly and allowing that this is going to add to your efficiency, even if it's clunky to begin with. But I don't know. I mean, I'd be really interested to hear about the hospitals who were successful and have been able to sustain that, because I know we've really struggled to launch and then to sustain. So, but I think it's a great, thanks for that, Bonnie. It's a good one for us to add in there as well.
Good deal. And then we can slide down to step 3. I think if everybody's ready for that. And
we just took a step here at the same thing about measures of impact of how will we know if we're diagnosing early? And this is going to be some of those metrics that, obviously we just threw a couple of the metrics out here that we'll be looking for some guidance and support in. But certainly if we start to see more diagnoses, identification of MCI, identification of dementia in the earlier phases, we'll know that we've had some impact in capturing people upstream of the moderate to end stage of disease where many people come into the system. Improving health outcomes and reducing complications. We know, again, when people are not diagnosed, but they have the diagnosis, their hospital course is often more rocky. And then competency rates of diagnosis across healthcare systems, which we've already talked about. Improving efficacy and reducing the burden for clinicians. That, we know that the frequent flyers, the people who come back, are often related to many of our seniors related to cognitive difficulties or diagnosis that has been missed in terms of dementia. That overall, while it might feel like it's a lot to incorporate into standardizing screening and protocols, it does absolutely, and the evidence bears that out, reduces the burden for clinicians by not having those repeats, back to bounce backs into the emergency rooms, et cetera. And then, of course, improving long-term care planning. We know that if people are diagnosed early, it puts them and their families in a much better setup for success in better financial planning, medical decision making, making sure that their powers of attorney are in place, their living wills. Not that we shouldn't all be doing that, but for many people, when we start to talk about eventually your capacity to sign these documents may be affected, and we want your voice in the room and on these documents. One of our measures that we threw out here of impact, knowing that we've made a difference and moved the needle, would be that. And then I think if you scroll all the way down, cost containment was also rolled into there. And if you put the time and the energy and the money into building the system with the right kind of training, that it really does bear out that there's a cost reduction in terms of inefficiencies. And that would be a place that I could see our consultant. Boy, this consultant's list just keeps growing and growing, but where I think the consultant could certainly add some support in mining that data for us. Anything else on that, Trey, or anybody else have some thoughts?
No, I think, for the most part, I mean, those are some key areas to really measure. There's a couple that, I'd be curious to hear everyone else's thoughts, but, really in how do we, present these measurements in front of certain audiences who may not be in it every day. So I think the cost containment component, once we're able to quantify that and look at potential cost savings on the back end of, if we do some of those things around early detection, so on and so forth, I think will be really, really helpful in just the overall, shaping of the narrative, in my opinion.
Hey, Trey, this is Bonnie. I wanted to just for a second talk about the first measure of impact, which is the identification of MCI. And what I'm going to talk about is more anecdotal than I don't have all of the statistics. But what we're seeing around the state is unprecedented number of clinicians who are diagnosing MCI when it might kind of be a more full-blown dementia, but they just don't want to diagnose it. And so with the measures of impact, I think we do have to be careful that more MCI diagnosis might be good, but it might be problematic as well.
A great point, Bonnie. Yeah, that's a very good point. It's a very good point. And I would say, Bonnie, to that, in that, from what you guys are seeing, is there a rationale behind it? From just, I don't know if you guys, are getting feedback on why, around that particular diagnosis, but I would just be curious to hear, I guess.
So I'm going to delegate this one to Jen, because I'm not a clinician, but what we have found is that patients want to, it's easier to tell a patient that, it's easier to accept that. And then the second part of it is it's unclear whether they actually are giving that diagnosis or that's kind of what the person leaves thinking. So it's just from our end, what we're seeing is confusion.
Yeah, I think that's a really good point, but I'll also add that in our geriatric clinic, I think that having this MCI identified gives clinicians another way of talking about the continuum of decline, because for many, they may say, if for some of our clinicians, it may be, gosh, they really don't meet full criteria and I'm uncomfortable going there. But they're also not, it's also not normal cognition. It's not normal aging. And so when this identification of MCI as a classification, I think it gave many clinicians a new tool to be able to say, here's what we know. MCI is a diagnostic category. 15% of the people per year will convert into a dementia diagnosis. When you talk about it in terms of those buckets, families can leave with, okay, I'm now fully prepared. This is not normal aging. There is something else going on here. I may plateau at MCI and stay there, or I might be part of that 15% every year that when I come back to my doctor in a year for another evaluation, it's converted to dementia. So when I look at measures of impact, without the MCI diagnosis, I think it handicaps clinicians, particularly clinicians who are not, who might be primary care docs. This is not really their only area of expertise. They often will be left with, well, it's not really bad enough. You don't have dementia. And I think the unfortunate message is people leave then going, I'm good. So you're just complaining that I'm not remembering, but I'm good. And then there's no good follow-up care. So I found that that seeing MCI diagnoses go up told me that we were also giving clinicians an educated tool to use to measure that cognitive changes. Jen, do you have some thoughts on that?
That's a great point, Lori.
Yeah, and I can see it going both ways. Certainly within a well, let me start with the question on those diagnoses, and you're never going to find from those orders is that a diagnosis, or are they using that as a symptom, right? So mild cognitive impairment, many people think of it as a symptom versus an actual diagnosis.
Right.
And there's not a super great way to distinguish that within like a medical record just by like running reports and ICD-9 codes and all of those kinds of things.
Mm-hmm.
So I think that that's one area certainly for education. How do we document that there's something going on here, but maybe it actually doesn't even meet the criteria for an MCI diagnosis. Maybe the person is coming in and they're actually normal aging changes, but how do you capture that in a way in the chart of something that it's been raised, there's a concern, so, I'll just put it in, there's complaint, patient's actually okay, and we'll just follow it versus that diagnosis. So I think that that's one area where education hopefully will help, that when you put this in the medical record, this is actually a diagnosis, and these are the types of things that can indicate. I also hear and agree, it certainly is a way for, in a specialty clinic or a primary care office who, works a lot with patients who have cognitive impairment, putting that in as that education, as that starter conversation. Some stay the same, some get worse, some actually get better over time. And how do we take that, like trying to get a diagnosis out of the medical record once it's in there is nearly impossible. So even those people who have recovered back to a normal cognitive profile, that diagnosis is kind of there with them for forever.
Mm-hmm.
So I see that in a specialty type of clinic. I think it gets more tricky in the primary care to distinguish kind of the difference between what Bonnie is saying and Lori, like those two. I think that's the tricky part, but I think that education could go a long way to review those types of things.
I think the fear of that diagnosis is once I'm tagged with that, then how does that impact me moving forward from insurance standpoint? Is coverage going to be more difficult? All those types of things are things that we need to address. There's really, for me, it's like the common theme between all three of these pillars is education and awareness. It is accessibility across diverse communities, and then the financial modeling. How can we make this affordable, either through insurance or just private pay? And I think that we, as a committee, if we can respond to those three things for the state of Ohio, those are the drivers. That would be a huge accomplishment, that people are aware of either early, what's the effects of a lifestyle, living a brain healthy lifestyle? What's the impact of early detection? And then how are we going to manage and mitigate once we have the disease? And then how are we going to afford that? It really plays across all three of these pillars, those three things. And I'm just thinking out loud that if we can respond to that, then I think we've done our job, really.
That's a great point, Greg, and a great segue given the time here to make sure that you and, well, you're going to be speaking for you and Tina if you guys want to report.
And Tina, yeah. So anything I say wrong is Tina's fault.
Exactly. Fully aware of that.
All right. So Trey, if you can, yeah. Let me share mine. I think this is it. Yes, so Tina and I worked on intervention and disease management. Our goal is that Ohio is leading the nation in clinical and professional standardized support and treatment of Alzheimer and related dementias. Some of the factors that go into it that create barriers for us is obviously education or lack thereof for professional and family caregivers, limited access to services, the lack of funding support, the time constraints that actual professionals have to invest in investigating cognitive issues, lack of regulations and rigid regulations that actually get in our way right now that we might have to change from a policy perspective. Let's see, disease and psych focused. Let's see, what is that? But not social focused. Oh, this was one that Tina came up with. So disease and psych focus versus not being social focused. I'm not exactly sure what that would be. She would be backing me up on that one. Lack of understanding for professionals towards effective treatments. So the clinical community really isn't aware of what are effective treatments. There are medications out there that most professionals are familiar with, but that's only part of the story. So taking a non-pharmacological approach versus a pharma approach. Social and economic barriers, as we just talked about, being able to cross over diverse communities. No continuity of care, and then creating or lack thereof good policies, and then affordability. So we summed it up into the three major barriers: is education for professionals and caregivers, access to support and limited services is another barrier, and then lack of funding for these types of services. How can we overcome that? Through what we believe is a statewide educational portal that presents a variety of learning styles, so everybody learns differently. I think it should have a variety of, things that, from videos to things that you can read, articles that you can read, and very easy for people to maneuver through. A lot of this will be seniors, 60, 70 and older. So the ability to navigate this platform very easily and have just a variety of ways of learning about all the things that go into cognitive care. Making sure that there's a strong certification platform for clinicians, and even caregivers for in the home, if it's possible that they can go through some type of certification online through the state platform, I think would be awesome. And then standardization of care, treatment, disease management and mitigation. Obviously the ease of navigation for people to get through the portal, to go through the process. What are my first steps when I have a diagnosis, or somebody in my family has a diagnosis of some form of dementia? What are the first steps I need to go through, all the way through interventions and disease management? Best practices. I think having a platform that speaks from a clinician standpoint as well as home care. What are best practices? What can you do in your own home to help promote independent, safety, and a high quality of life, as well as from the professional side as well, within institutional care, and then obviously the clinicians that are helping to push things forward. And then I think having a strong network of group support for any level within the professional ranks, as well as more in the general public. So that would be sort of our educational portal that helps to guide all those different things. improved regulation and policies, so standards of training. There are some out there, but I think they need to be tightened up. Not too rigid, because you don't want to prevent innovation, but I do believe that where it's set right now is a very low level of expectation. And I always tell my team that if we're operating at state level, we're operating at the bottom of our license, and we want to be at the top of our license and constantly pushing and innovating. So I think raising that bar will benefit all of Ohio. So doing the right policies on those types of things and regulations. Treatment methodology that's widely accepted. So what would that look like? How do we define that? And how do we set a standard on that? And then put that in some type of regulation or policy that aims everything towards that. Specific trade organizations. Now I know we have the Alzheimer's Association, but I think really having a thing that's specifically focused on dementia, where we're doing trade events, raising money, all that kind of stuff. I know that the Alzheimer's Association does a lot, but I would like them to start doing trade events and things that are specifically educating on treatments and the different types of things that we can do to fight back against cognitive decline. And then funding mechanisms, insurance that is willing to fund and support all stages, from education, preventative measures through early detection, all the way through interventions and disease management. Make intervention and disease management affordable. Yeah, so how do we make these interventions affordable is something that we need to tackle, and it could be through a variety of things. One of which would be forcing insurance companies to participate in that. Right now, the only way I really know how to deal with once you've been diagnosed with some form of dementia to fight back on it is private pay. And we've got to get away from that model and make sure that insurance is really making it more affordable for us. And then bringing it to the community. How do we support? So if mom's diagnosed, what local support do you have? You shouldn't have to go to another city to get the type of support that you need. So making sure that it's driven down to local community for those interventions. And then, so we thought of 3 different measures of impact. Ohio, it's a pretty easy to know, hey, we have a portal. It's very easy to navigate. It does all the things that we want it to do. So that would be one measure, that we actually have a tool for professionals and the general public to use. And then regulations and policy that really support intervention and disease management. And then insurance policies that are paying for intervention and disease management. And that's really it. Any questions?
I think it looks great. When you say that's really it, I think, the big piece about the finance and, we need a different model. Every single day we're faced with patients who are forced into Medicaid, nursing home care, guilt of what all that means because they absolutely cannot afford to navigate. And I think you hit the nail on the head. And I would certainly say that I think, well, it might be a one-liner in here. It's the biggest nut that I think absolutely we owe it to families to do a better job with that.
All right. Anything else?
All right. Any other questions for anybody? Thoughts on anything?
So this is Bonnie, and we somehow in this we kind of did lose the end of life part. Mm-hmm. And I know that there's some Jiminy Crickets on my shoulder saying, where is that? Mm-hmm.
I think we did talk about that could be another that we could approach after we did these 3 pillars. We thought it was enough to do in a week
Yeah,
to sort of nail this down. But I do agree that that's something we should look at.
The only reason I bring it up is I think we do have a committee meeting next, I just don't want the committee to think that it wasn't important, that's all.
Right, no, that's a great point, Bonnie. And I think, there's the 2 dangling pieces out there as we were trying to just do this in bite-sized pieces. End-of-life care and how it dovetails, because as you even just start to think about what's that going to look like, I think that begins in the earliest stages of the process. We're talking about wanting to capture people upstream of their disease where they have a voice, they have legal autonomy to sign forms. All of that ties into end-of-life care. It's not just about what are we doing at the end of life care. So I think of that as, again, kind of that pull through, but we probably, again, definitely need to make that very clear and delineate that. And then remember, the other piece that's still dangling over here is we're tasked as a subcommittee to address or somehow dovetail and integrate our work into the state's plan, which is why we were trying to keep these buckets and these pillars in a way that makes that integration a little bit easier. Because it's huge when you read that paragraph of, okay, just solve the world's crisis here around dementia, find a way to pay for it, and make sure that it's an easy flowing process. We know that there's a lot of moving parts in this. So what are your thoughts about our next steps now that we've kind of navigated and took a little deeper dive on these 3 pillars, knowing we've got end of life floating up here and ultimately integration into the end of life or into the state's plan? What would each of you propose to be our next steps to move us closer to that goal?
Oh, that's a good question.
Well, isn't our committee meeting next week?
You mean
I don't see it on the calendar. I just looked ahead. Usually, I don't see it on my calendar.
Oh, okay, maybe it's in 2. Oh, and so
yeah, it's on the 24th. So next week, we do not have a scheduled meeting on the 17th, which we probably should, I would say.
I'm sorry. Can I go back? I don't have the state's meeting on the 24th. Does anybody else have that on for the 24th?
No, I do not either.
No.
I have it TBD.
31st is Memorial Day, so.
Right.
So
Yeah, the 31st is Memorial Day parade, so, okay.
I have it on the 24th.
You do? Okay. Right. And if I could, if we could get the agenda, maybe I know that's been coming out like 15, 20 minutes beforehand, which is fine if it's a simple agenda, but for me, looking at how can we report off from our subcommittees, having that agenda a little bit sooner would be helpful, I think. Okay, thank you. So then that means if, and I did not have us down for the 17th, and that's going to be a little tough for me with my schedule, but I don't know. What are you all suggesting?
I mean, maybe we can just convene back in the groups and then just try to work through any additions, subtractions, etc. Since we probably the 17th will be tough for me as well. So if we can go back in at least the individual groups, it may be easier for us to schedule meetings with 2 of us as opposed to the entire group, clean up everything, and I think send it back out. And I think what I noticed too is there's a lot of synergies even between areas that we've all addressed. And Greg, I think you alluded to it earlier. You kind of got 3 narratives that's coming out of all of this work. So maybe at some point when we update everything, send that back out and then start to consolidate. because that way, to me, when the consultant comes on board, we're kind of giving them almost a package with a list of items that we need from them. So
Yeah.
I guess that's just how my brain is working. Just try to consolidate and be prepared for when they come on board.
Hey,
And
Craig, can I ask you, didn't we originally had different buckets? What is going to happen to that information from the original presentations that we did to the subcommittee? You know, because for example, Jen and I were long-term care and something else. So are we losing that? Are we going to put it into these things? How's that going to work?
You know,
I think
for
it-
me, Bonnie, I
oh,
think
go
it's a
ahead.
great question of how the issue was, how can we take this and keep funneling? So I don't see it, my hope is that we're not losing the richness of those documents, but the largesse of them was, I think, almost not manageable because we couldn't identify the themes to turn over to the support of the consultant. So I look at it as maybe when we go back to our groups, we're continuing to take that and integrate it and distill it down, and maybe now making sure that we're also addressing how end of life care weaves into that. And Tessie, maybe if we could get a peek at, or if there's a quick link that you could send out for the state's plan, because I know as part of the science committee, our role is also to integrate and dovetail that into the existing plan. Maybe if we could have that as the backdrop when we're working in teams, that might also be helpful. Does that make sense to everybody?
Tell me that again. What were you saying? What would be that next? Just repeat what you just said. I'm sorry, I was looking at the document.
I was just responding to Bonnie's comment about, we did the richness of that original documents. We don't want that data to go away. We want to make sure that when we're back into our teams that we're pulling it down and distilling it, looking at tighter themes, not losing the information, but integrating it tighter, and maybe adding in, making sure that we're looping back in long-term or end of life care, and then asking Tessie to send out a link that we can have access to the state's plan, because we know that in our bucket for the science committee, one of the things that we're tasked with is tying that into the state's plan, tying our work into the state's plan. So,
gotcha.
All
right.
And if we do that in our, at times where we're just meeting with our partner, then the going forward might be, we skip next Monday. It sounds like we have the larger group on the 24th. And then, then the next Monday is Memorial Day, which would mean either then we pick a different day of the week or we move to June 7th to reconvene as a subcommittee.
Yeah, I'm almost thinking we should maybe just for that following Monday, since it's, maybe we just push the Tuesday on that date now, or do you want to wait another, because that's going to be then almost a month before we meet again, if we wait till the 7th.
Greg, would it be all helpful to, because somewhere in one of those days is when the consultant will be joining, and if someone from ODA could let us know what that is, we might want to schedule so that the consultant can be a
Based
part
on that.
Yeah, that's a great idea.
Yeah, we might find out more on our next meeting. So yeah, maybe we'll just hold off before we schedule, and then we can connect and figure out what the best date is.
Yeah.
Okay. So I think one of the things that I have lost track of is also that Excel diamond sheet that we did. And so I don't know if now or in the next couple of weeks, that's another thing to kind of crosswalk and bring together to make sure that everything on that is something that is being thought of, in maybe a little bit more specific detail than what's on our current sheet. So the one I had just pulled it up, and one of the things was, specifically and maybe I didn't quite catch it in the conversation, the legal protections for and faced by, folks living with Alzheimer's, or related dementias. That's probably looped in with a lot of the conversation we've had, but making sure we are pulling out some of those more specific things, I think would be important.
Yeah, I think you're right.
Yeah, so going back and cross-referencing to the diamond sheet, making sure that we're covering those things. So I can send that out if you all don't have it. So I'll plan on resending that out just so you have it. And then do we want to do anything between now and whenever related to end-of-life care? A worksheet on end-of-life care, or is that sort of spilling over from other things?
My suggestion is that we roll it into the work that we're doing as opposed to creating it as a separate pillar. I think it's hard to segment that out. And if our ultimate goal here is to not silo the care, but see the care as integrated, I think, again, end-of-life care, as I said before, I think starts, early on when everybody is cognitively healthy and able to participate in those legal documents before we get into capacity evaluations and they are no longer able to. So, and then that goes all the way through to, how are we providing end-of-life care to people with dementia truly at the end stage? So I don't know. My bias would be that we just take it into our teams and we make sure that it's woven in there. And maybe as Jen said, cross-referencing to make sure, I'm not remembering if there was a diamond specific to that, but making sure that it's in there. Okay.
Okay.
I like that.
I'll note that. Yep, that makes sense.
And if I'm not mistaken, I only did a first run through the state's plan. I think there is a component in there that addresses end-of-life care. So we want to make sure our language dovetails. So.
All right.
Anything else from anybody? Ready to adjourn?
I am.
All right. So with that, we will adjourn the meeting for today, and we'll meet in our teams, and then we'll reconvene back with the larger group on the 24th, and we'll stay connected with Tessie to find out when the consultant might be scheduled for a meeting. To Bonnie's point, that maybe we could then schedule our subcommittee meeting to meet also with that consultant. So, all right, everybody. Thanks. Have a great.
Thank you all.
Thank you.
Thanks, Tessie.